A patient is given aspirin 300 mg after developing an acute coronary syndrome. What is the mechanism of action of aspirin to achieve an antiplatelet effect? Can't remember. Glycoprotein 3A receptor antagonist is the job of heparin, or low molecular heparin. How does aspirin do it? I think it inhibits ADP. Let's just try. No, the answer is inhibits production of thromboxane A2. Do you have Ninja? No, it's worth going through his video. He explains the coagulation cascade, clotting, platelet mesh formation to a lot of detail. So aspirin works by blocking the action of both cyclooxygenase 1 and 2. Cyclooxygenase is responsible for prostaglandin, prostacycline, and thromboxane synthesis. The blocking of thromboxane A2 formation in platelets reduces the ability of platelets to aggregate, which has led to the widespread use of low-dose aspirin in cardiovascular disease. Until recent guidelines changed all patients with established cardiovascular disease to aspirin if there was no contraindication. Following the 2010 technology appraisal of clopidogrel, this is no longer the case. Two recent trials, the aspirin for asymptomatic atherosclerosis and the antithrombotic trial-less collaboration, have cast doubt on the use of aspirin in primary prevention of cardiovascular disease. Guidelines have not yet changed to reflect this. However, the Medicines of Healthcare Products Regulatory Agency (MHRA) issued a drug safety update in January 2010, reminding prescribers that aspirin is not licensed for primary prevention. What do the current guidelines recommend? First line for patients with ischemic heart disease, potentiates oral hypoglycemics, warfarin steroids. Aspirin should not be used in children under 16 due to the risk of Reye's syndrome. An exception is Kawasaki disease, where the benefits are thought to outweigh the risk. NICE now recommend clopidogrel first line following an ischemic stroke and for peripheral arterial disease. For TIAs, the situation is more complex. Recent Royal College of Physicians guidelines support the use of clopidogrel in TIAs. However, the older NICE guidelines still recommend aspirin plus dipyridamole, a position the RCP states is illogical. Okay, let's first go to go and see where thromboxane A2. Okay, just remember aspirin blocks prostaglandin, prostacycline, thromboxane. Prostaglandin, prostacycline, thromboxane, since it blocks cyclooxygenase COX inhibitor, right? And let's go to Ninja Medicine and see how the coagulation happens. This is the one, I think.
Pause. Contraction leads to vasoconstriction. And then again, what will that log line with that with the glycoprotein 1B, right? So here's a mechanism in response to that, and it's called a myogenic mechanism. So if there's direct injury or contact, the smooth muscle will contract. So again, what's the second mechanism? This is called a myogenic mechanism. Okay, so whenever there's direct injury or contact with the smooth muscle, it contracts. Third event. You see these orange receptors here, these orange neurons? Whenever there's inflammation, you release specific types of inflammatory chemicals. So there's a lot of inflammatory chemicals within this area. A lot of inflammatory chemicals, like maybe some histamines and some leukotrienes and some prostaglandins. What are they going to do? They're going to stimulate these actual orange neurons, right? These nociceptors. And whenever they stimulate, they're going to initiate pain, but that pain reflex can cause vasoconstriction. So whenever these neurons are stimulated, these nociceptors, due to local inflammatory chemicals or mechanical trauma, so in other words, there's direct injury to them as well, they're going to initiate a reflex that causes contraction. So again, what will happen here? You can initiate contraction onto this actual smooth muscle cell. And whenever there's contraction, that will cause the vascular spasm also. So again, what's the third effect? Nociceptor activation. So three mechanisms that trigger this vascular spasm event, right? So that's that part. Now, let's go into the second event, because we've already gone over how we're trying to prevent this from happening. Let's go ahead and do the second event. What's the second event now? All right, so now, when there's damage to these endothelial cells, right? Damage to the endothelial cells, maybe damage to the collagen, maybe damage to the smooth muscle. What happens is, there's a protein. There's a protein produced by the endothelial cells. Look at this. See this protein right here? This protein is called von Wildebrand Factor. Von Wildebrand Factor. So again, what is this protein called? It's called von Wildebrand factor. So this protein is secreted by the injured endothelial cells, right? And what happens is, normally the platelets love to bind to the collagen because it is von Wildebrand factor. If these cells are injured, can they release nitric oxide? Can they release prostacycline? No. So the platelet is not kept inactivated. So that platelet is actually going to bind. And on top of that, if we don't have heparin sulfate because maybe it's damaged and there's heparin sulfate right here, can we keep some of those clotting factors inactive? No. And if we have thrombomodulin right there and that was damaged, can we actually keep the blood thin from factor 5 and factor 8? No. So this will trigger that coagulation cascade, right? But first we need to do platelet plug. So again, nitric oxide and prostacycline is inhibited, and then the platelets will come and bind here. So look, here's a platelet right here, and here's a platelet right there. They'll bind. But on the von Wildebrand factor, so let's say here's the von Wildebrand factor, there's a specific receptor on the platelet that binds with the von Wildebrand factor. What is this glycoprotein called? And the only reason I mention it is because it's important because we have to understand certain diseases and drugs. That protein right there is called, that black protein is called glycoprotein 1b. So again, what is that protein called right there? It's called glycoprotein 1b, and it binds with the von Wildebrand factor. So the platelets bind here, right? And then what happens? Once the platelets are actually going to be like activated because of this binding, their granules start actually releasing specific chemicals. What are those chemicals that it secretes? 3 chemicals it secretes. One of these chemicals is called ADP, right? That's one really, really important one. Another chemical is called thromboxane, A2, and another chemical it secretes is called serotonin, or 5-hydroxytryptamine. What do these chemicals do? Well, I told you before that there's platelets just kind of naturally circulating within this area right here, right? So maybe here's a platelet, maybe here's a platelet, maybe here's a platelet, here's a platelet, right? These platelets are just tiny little cytoplasmic fragments. They're super, super tiny. They're derived from the megakaryocyte, right? So what happens is ADP and thromboxane A2, these guys work to be able to stimulate these actual platelets. So they have receptors on their membrane that specifically bind the ADP and the thromboxane A2. So when ADP and thromboxane A2 bind onto these platelets, it activates the platelets and causes these platelets to want to come to that site of injury. So then what's going to happen? These platelets are going to start aggregating to that site of injury. So they're going to undergo, what's this called whenever they come here? It's called platelet aggregation. That's the first step, all right? So now the platelets are going to start binding here. So look at what's happening here. So platelets bind here, they bind here, they bind here, and they start forming this nice plug right here. But then there's one more thing that we have to do before we keep going on with this, right? So the platelets are binding, but how are they binding to each other? We know how they bind with von Wildebrand factor. Let me draw a platelet right here. So here's one platelet, and here's another platelet. So we know that they can join with the von Wildebrand factor, right? So here's, let's say here's the von Wildebrand factor protein. They bind with that with the glycoprotein 1b, right? So here's our glycoprotein 1b. That's how they bind this. But how do they bind to each other? Well, here's another. There's these proteins here on each one surface, and then there's a thing called fibrinogen that actually links them together. This protein right there is called, get ready, glycoprotein 2b3a. Holy goodness, right? That's a crazy name right there, but it's important because we have to know these proteins because they're drug targets, okay? So again, glycoprotein 2b and 3a with fibrinogen between them link the platelets together. So that's what you'll see linking them together. But now look, we got a nice platelet plug. Okay, we're not done yet. What is thromboxane A2 and what else does serotonin do? We see these actual pink, these purple receptors down here. Thromboxane and A2 and serotonin love to bind to the smooth muscle. And when they bind onto the smooth muscle, they cause contraction. So again, what will they cause? Let's come down here, they cause contraction, right? And what does contraction cause? Contraction leads to vasoconstriction, and then again, what will that vasoconstriction do? Enhance the vascular spasm effect. So again, ADP and thromboxane A2 cause platelet aggregation, which leads to this platelet plug, but thromboxane A2 and serotonin cause vasoconstriction to enhance the vascular spasm effect. That is the second step. So what is the second step right here that we've done? It's called platelet plug formation. Not bad, right? All right. So we've done the second step. So we've done first step, second step, now let's go on to the third step. Okay, so now, real quick recap is what this will be, right? So again, there's damage to this endothelial lining. We already know what happens. Von Wildebrand factor is going to be right here, right? And it's going to have its specific proteins there. What's going to bind? Platelets, and they're going to bind with their glycoprotein 1b. They're going to bind to each other through their glycoprotein 2b3a with the fibrinogen in between them. They're going to start becoming activated and secreting ADP and thromboxane A2, which causes platelet aggregation. And then they're going to secrete serotonin, and then thromboxane A2 also will cause vasoconstriction to enhance vascular spasm, right? So now we got this beautiful platelet plug here. Now we go into the bear of it all right? Now we're going to go into coagulation.
Okay, so this is why important for aspirin, clopidogrel, and all the antiplatelet agents, right? So aspirin works on the thromboxane A2 part of this platelet plug formation. Okay, now we go and study the guidelines for stroke management. As it says, aspirin is no longer used as primary prevention. Now clopidogrel is the first line. This is not primary, this is secondary prevention. So let's go have a look. No summary. Resource. No summary. Guess we go to the pathway. I don't think that's the summary. rapid recognition of symptoms. Use a validated tool such as FAST outside hospital to screen for people with sudden onset neurological symptoms for diagnosis of stroke or TIA. Exclude hypoglycemia and people with sudden onset neurological symptoms as the cause of these symptoms. For people who are admitted to emergency department with suspected stroke or TIA, establish a diagnosis rapidly using validated tools such as Rossier. Recognition of stroke in the emergency room. Then you either have TIA or acute stroke. TIA is symptoms last less than 24 hours. Stroke, the symptoms last more than 24 hours. But in an acute setting, you wouldn't know whether there's a TIA or stroke unless the patient's symptoms actually resolve before they come to you. Let's look at TIA. Initial management. Offer aspirin 300 mg daily unless contraindicated to people who have had suspected TIA to be started immediately. Refer immediately people who have had a suspected TIA for specialist assessment and investigations to be seen within 24 hours of onset of symptoms. Do not use scoring systems such as ABCD2 to assess the risk of subsequent stroke or to inform urgency of referral for people who have had a suspected or confirmed TIA. Offer secondary prevention in addition to aspirin as soon as possible after the diagnosis of TIA is confirmed. Brain imaging. Do not offer CT brain scanning to people with suspected TIA unless there is clinical suspicion of an alternative diagnosis that CT could detect. After specialist assessment in the TIA clinic, consider MRI, including diffusion weighted and blood sensitive sequences to determine the territory of ischemia or to detect hemorrhage or alternative pathologies. If the MRI is done, perform it on the same day as the assessment. Assessing and managing carotid stenosis. Everyone with TIA who are after specialist assessments is considered as a candidate for carotid endarterectomy should have urgent carotid imaging. Ensure that people with stable neurological symptoms from acute non-disabling stroke or TIA, stroke with symptoms that last for more than 24 hours but later resolve, leaving no permanent disability, or TIA, transient ischemic attack, stroke symptoms and signs that resolve within 24 hours, who have symptomatic carotid stenosis of 50% to 99%, are assessed and referred urgently for carotid endarterectomy to a service following current national standards. Receive best medical treatment, control of blood pressure, antiplatelet agents, cholesterol lowering through diet and drugs, lifestyle advice. Ensure that people with stable neurological symptoms from acute non-disabling stroke or TIA who have symptomatic carotid stenosis of less than 50% according to the NASET criteria or less than 70% according to the ECST criteria do not have surgery. Less than 50% no surgery. Receive best medical treatment, control blood pressure, antiplatelet drugs, cholesterol lowering through diet and drugs, lifestyle advice. Ensure that carotid imaging reports clearly state which criteria, CCST or NASET, were used when measuring the extent of carotid stenosis. Interventions that should not be used. We're not going to talk about that in preventing further occlusive vascular events. Clopidogrel and modified release dipyridamole. The following recommendations are an extract from NICE Technology Appraisal. Modified release dipyridamole in combination with aspirin is recommended as an option to prevent occlusive vascular events for people who have had a transient ischemic attack. Modified release dipyridamole alone is recommended as an option to prevent occlusive vascular events for people who have had a transient ischemic attack only if aspirin is contraindicated or not tolerated. People currently receiving modified release dipyridamole, either with or without aspirin outside this criteria, should have the option to continue treatment until they and their clinicians consider it appropriate to stop. Okay, so in TIA, the current NICE recommendation is modified release dipyridamole with aspirin. And then first is always aspirin 300 mg. And then after that, you want to offer secondary prevention as soon as possible after diagnosis of TIA is confirmed. So probably your aspirin will reduce to 75 mg, and you add your modified release dipyridamole. Okay, now that's for TIA. Let's look at stroke, acute stroke. When to perform brain imaging? Perform brain imaging immediately with a non-enhanced CT for people with suspected acute stroke if any of the following apply. The committee defined immediately as ideally in the next slot and definitely within 1 hour, which is sooner. Whichever is sooner. Okay. Indications for thrombolysis or thrombectomy, on anticoagulant treatment, a known bleeding tendency, a depressed level of consciousness, GCS below 13, unexplained progressive or fluctuating symptoms, papillary edema, neck stiffness or fever, severe headache at onset of stroke symptoms. If thrombectomy might be indicated, perform imaging with CT contrast angiography following initial non-enhanced CT. So after your plain CT, you want to do non-enhanced a CT contrast CT head, CT contrast angiography, or it's not a CT head, it's an angiography. CT perfusion imaging or MR equivalent if thrombectomy might be indicated beyond 6 hours of symptom onset. Perform scanning as soon as possible and within 24 hours of symptom onset in everyone with suspected acute stroke without indications for immediate brain imaging. Intracerebral hemorrhage. People with intracerebral hemorrhage should be monitored by specialists in neurosurgical or stroke care for deterioration in function and referred immediately for brain imaging when necessary. Oxygen therapy and blood sugar control. Supplemental oxygen therapy. Give supplemental oxygen to people who have had a stroke only if their oxygen saturation drops below 95%. The routine use of supplemental oxygen is not recommended in people with acute stroke who are not hypoxic. Blood sugar control. Maintain blood glucose concentration between 4 and 11 with acute stroke. Provide optimal insulin therapy, which can be achieved by the use of intravenous insulin and glucose to all adults with type 1 DM with threatened or actual stroke. Critical care emergency departments should have a protocol for such management. So let's see what happens in ischemic stroke. So you either want to thrombolyze or thrombectomy, aspirin, other antiplatelet therapeutic, hypothermia, blood pressure control, antiplatelet, anticoagulant treatment. Okay, let's look at thrombolysis first. I think within 4.5 hours only. The following recommendation is from NICE Technological Appraisal Guidelines on alteplase for treating acute ischemic stroke. Alteplase is recommended within its marketing authorization for treating acute ischemic stroke in adults if treatment is started as early as possible within 4.5 hours of onset of stroke symptoms. Intracranial hemorrhage has been excluded by appropriate imaging techniques. Okay, how about aspirin or other antiplatelet treatment? Offer the following as soon as possible, certainly within 24 hours, to everyone presenting with acute stroke who has had a diagnosis of intracerebral hemorrhage excluded by brain imaging. Aspirin 300 mg orally if they do not have dysphagia, difficulty swallowing, or aspirin 300 mg rectally or by enteral tube if they do have dysphagia. Continue aspirin daily 300 mg until 2 weeks after the onset of stroke symptoms, at which time start definitive long-term antithrombotic treatment. Start people on long-term treatment earlier if they are being discharged before 2 weeks. Offer proton pump inhibitor in addition to aspirin to anyone with acute ischemic stroke for whom previous dyspepsia associated with aspirin is reported. Offer an alternative antiplatelet agent to anyone with acute ischemic stroke who is allergic to or genuinely intolerant of aspirin. Aspirin intolerance is defined as either of the following: proven hypersensitivity to aspirin containing medicines or history of severe dyspepsia including induced by low-dose aspirin. Do not use anticoagulation treatment routinely for treatment of acute stroke. There may be a subgroup of people for whom the risk of venous thromboembolism outweighs the risk of hemorrhagic transformation. For people considered to be at particularly high risk of venous thromboembolism include anyone with complete paralysis of the leg, a previous history of venous thromboembolism, dehydration, or comorbidities such as malignant disease, or who is a current or recent smoker. Such people should be kept under regular review if they are given prophylactic anticoagulation. Okay, so aspirin 300 mg for 2 weeks. After that, go to long-term antiplatelet. Right. Thrombectomy. Offer thrombectomy as soon as possible and within 6 hours of symptom onset, together with intravenous thrombolysis if not contraindicated, and within the licensed time window to people who have acute ischemic stroke and confirm occlusion of the proximal anterior circulation. Anterior circulation includes the MCA and ACA, right? It has to be proximal, so you can put in the extractor. If it's too small of a vessel, probably can't reach, or it's not worth the risk. Taking into account the factors in the recommendation on overall clinic status below. Offer thrombectomy as soon as possible to people who were last known to be well between 6 hours and 24 hours previously, including wake-up strokes, who have acute ischemic stroke and confirmed occlusion of the proximal anterior circulation demonstrated by CT angio or MR angio, and if there is potential to salvage brain tissue as shown by imaging such as CT perfusion or diffusion weighted MRI sequences showing limited infarct core volume. Taking into account the factors in the recommendations on overall clinical status below, consider thrombectomy together with intravenous thrombolysis where not contraindicated and within the licensed time window as soon as possible for people last known to be well up to 24 hours previously, including wake-up strokes who have acute ischemic stroke and confirmed occlusion of the proximal posterior circulation demonstrated by CTA or MRA, if there is potential to salvage brain tissue as shown by imaging such as CT perfusion or diffusion weighted MRI sequence showing limited infarct core volume. Overall clinical status: take into account the person's overall clinical status and extent of established infarction on initial brain imaging to inform decisions about thrombectomy. Select people who have, in addition to the factors mentioned in the 3 recommendations above, a pre-stroke functional status of less than 3 on the MRS and a score of more than 5 on the NIHSS. Okay, there is a score, I guess, for functional status. And then you have therapeutic hypothermia. Should not be used. Okay, should not be used. It shouldn't be here then. Antiplatelet and anticoagulant treatment for complex presentations. Cerebral venous sinus thrombosis. Offer people diagnosed with cerebral venous sinus thrombosis, including those with secondary cerebral hemorrhage, full dose anticoagulation treatment, initially full dose heparin and then warfarin INR 2 to 3 unless there are comorbidities that preclude its use. Offer either anticoagulants or antiplatelet agents to people who have stroke secondary to acute arterial dissection. Let's not talk about complex. presentations. Let's just focus on the simple ones first. Master the simple ones before going to all this. Okay. Blood pressure control, antihypertensive treatment in people with acute ischemic stroke is recommended only if there is a hypertensive emergency with one or more of the following serious concomitant medical issues: hypertensive encephalopathy, hypertensive neuropathy, hypertensive cardiac failure or myocardial infarction, aortic dissection, preeclampsia or eclampsia. Blood pressure reduction to 185 over 110 mmHg or lower should be considered in people who are candidates for intravenous thrombolysis. Okay. So keep BP below 185 over 110. So overall, what is that management of acute specialist stroke unit? Assessing, swallowing function, planning, early mobilization, statin treatment. Oh my. Okay, so far what we know is thrombolysis within 4.5 hours, thrombectomy within 6 hours, or within 24 hours if the CTA MRA shows proximal blocking of the anterior circulation, which is the MCA or ACA, or internal carotids, or and the DWI, diffusion weighted imaging, shows that the area is not too big and is salvageable. Other than that, you want to give aspirin 3 aspirin 300 mg, 300 mg aspirin 300 mg once you exclude a bleed. So you do a plain CT scan, you exclude a bleed, then you give aspirin 300 mg for 2 weeks. After 2 weeks you want to change to regular antiplatelets. Other than that, you want to control hypertension. If keep the blood pressure below 185 over 110 mmHg. You don't keep it too low because you will reduce perfusion to the brain in an ischemic patient, in an ischemic stroke. Then in the specialist stroke unit, let's look admission to acute stroke unit after initial assessment from either the community emergency department or patient clinics. Swallowing function, okay, positioning, optimal hip position, comfort, blah blah blah, early mobilization. In the first, do not offer high intensity in the first 24 hours. Help people with acute stroke to sit out of bed, stand or walk as soon as their clinical condition permits, and part of the active management program in specialist stroke unit. Statin treatment, immediate initiation of statin treatment is not recommended in people with acute stroke. The consensus of the committee is that it would be safe to start statins after 48 hours because there is a risk of hemorrhagic transformation, I think. Continue statin treatment in people with acute stroke who are already receiving statins. Okay. Consider decompressive hemicrionectomy for MCA infarction. It's a bit advanced. Assessing managing carotid stenosis. Okay, more than 50% of the NASET criteria, you're gonna offer carotid endarterectomy. Deep vein thrombosis, treat. Either anticoagulation or cable filter. Intervention that should not be used, not gonna talk about that. Prevention of further occlusive vascular events. Clopidogrel, right, this is what we want to know. Clopidogrel and modified release dipyridamole. The following recommendations are an extract. Okay, clopidogrel is recommended as an option to prevent occlusive vascular events for people who have had an ischemic stroke or who have peripheral arterial disease or multivascular disease. Modified release dipyridamole in combination with aspirin is recommended as an option to prevent occlusive vascular events for people who have had an ischemic stroke only if clopidogrel is contraindicated or not tolerated. So modified release dipyridamole alone is recommended as an option to prevent occlusive vascular events for people who have had an ischemic stroke only if aspirin and clopidogrel are contraindicated or not tolerated. Treatment of clopidogrel to prevent occlusive vascular events should be started with the least costly licensed preparation. People currently receiving clopidogrel or modified release dipyridamole either with or without aspirin outside these criteria should have the option to continue treatment until they and their clinicians consider it appropriate to stop. Okay, so TIA, you give aspirin 300 mg. You would not do a CT hit routinely. However, you might want to do a DWI to see which areas of infarct and refer to specialist stroke unit within 24 hours. And in the specialist stroke unit, did I mention 300 mg aspirin? Yeah, once you confirm TIA, then you change the aspirin to the regular antiplatelets, which would be, in the case of TIA, according to NICE guidelines, modified release dipyridamole in combination with aspirin. Whereas in stroke, you'll want to first do a plain CT to rule out hemorrhagic stroke, and then if it's within 4.5 hours, and you want to see the functional level of the patient using some criteria, and then if they're eligible, go for thrombolysis using LT-place within 4.5 hours. If within 6 hours, consider thrombectomy, and if the CTA or MRA shows a proximal clot in the anterior circulation, and DWI shows salvageable, you can even do up to 24 hours. Definitely you want to, after you rule out the hemorrhagic stroke, then you want to start them on aspirin 300 mg, and then for 2 weeks, and then after that switch them onto the regular antiplatelets, which in this case is, in the case of stroke, according to NICE guidelines, is clopidogrel. It's the first line. Other than that, statins should not be started within the first 48 hours because if I'm not mistaken, because of the risk of hemorrhagic transformation. Keep BP below 185/110 mmHg. What else? Yeah, I think that's all right. Okay.